Welcome to the ADA's 85th Scientific Sessions. Please take your seats. The event is about to begin.
To move us closer to a world free of diabetes, we need people with clear vision, strong minds, and big hearts. The American Diabetes Association is thrilled to honor professionals who have shown all of those vital qualities and have made significant contributions to diabetes research or care. This year's awards go to These doctors, scholars, researchers, and changemakers are doing the work that makes a difference. Because of them, more people living with diabetes can thrive. We thank them all for their contributions.
The Distinguished International Service in the Cause of Diabetes honors individuals who have demonstrated outstanding research, evaluation, and care in diabetes performed from an international perspective with an international impact. The 2025 award goes to Dr. K.M. Venkat Narayan. K.M. Venkat Narayan is an international expert at the vanguard of diabetes research, training, policy, and advocacy. Formerly intramural researcher at NIDDK and diabetes science lead at CDC, Narayan leads the Emory Global Diabetes Research Center, EGDRC. EGDRC is a thriving interdisciplinary center seamlessly pursuing diabetes prevention and care in the U.S. and worldwide. Narayan's research is exemplified in his over 650 publications, 22,000 citations, H-Index 149. He won ADA's Kelly West Award for Outstanding Achievement in Epidemiology. Narayan led the World Bank's disease control priorities for diabetes, and his contributions have encompassed memberships of the IDF Diabetes Atlas Committee, WHO Committees on Diagnosis and Classification, NIDDK ICMR Working Group, UN Summit on NCD, and leadership of the Global Diabetes Centers Forum. Narayan was Danish Diabetes Academy Visiting Professor at University of Copenhagen, Visiting Nehru Chair at University of Hyderabad, and is a member of the U.S. National Academy of Medicine and Foreign Fellow of the Indian National Science Academy. Dr. Narayan will now deliver the 2025 Distinguished International Service in the Cause of Diabetes Award Lecture.
Thank you, American Diabetes Association. Good morning, my dear friends. It is truly an honor to be giving this talk. Truthfully, this award belongs to my extensive network of colleagues and collaborators with whom I've had the opportunity and privilege to work on the global aspects of diabetes for the past 2 decades. To every one of them, I dedicate this talk. I have no conflicts of interest. I want to start by thanking my colleagues at the Emory Global Diabetes Research Center, an interdisciplinary group of 150 faculty, many fellows, students, and staff. I particularly want to thank Mark Hutchison, our managing director, and some of my very close colleagues, Moali, Solveig Cunningham, Mary Beth Weber, Lisa Steinmays, Anjali Gujral, Shivani Patel, Ram Jagannathan, Guillermo Umpierrez, Wei Shao, Janssen, Karen Siegel, Elizabeth Rhodes, and many others. I want to also thank Catherine Graves and the trusted advisors of the Emory Global Diabetes Research Center, who have supported us with their generous contributions and their strategic advice. I would be amiss if I did not mention my major collaborative partners in India, where we have strategic partnerships with over a dozen institutions. I particularly want to thank Dr. Mohan, who is in the audience here today, and who was our first collaborator in India. My thanks are also due to Dr. Nikhil Tandon, Prabhakar, Anura Kurpad, Dr. Sashikala, and many others. Over the years, the Emory Global Diabetes Research Center has had partnerships with over 25 countries, with over 100 active or completed projects thus far. This extensive network has really been the basis upon which a lot of our work has been accomplished. I must recognize the large number of international fellows, over 250, who have visited Emory, spent between a few weeks to a few months, trained in global diabetes, and returned home to their home countries and continued to collaborate on global diabetes. Simultaneously, we've had many US fellows, almost 40 of them, doctoral and postdoctoral fellows, spending up to a year in low and middle income countries, largely in India, but in other places as well. This network of young fellows across low and middle income countries and in the United States has been one of our most endearing and enduring contributions. Finally, I should thank my immediate family, my wife Asha Krishnaswamy and daughter Sarayu Narayan, who are unfortunately not here today. My mother, Mrs. Jayalakshmi, is in the audience. I was born posthumous to my dad, and I'm my mother's only child. I owe her a lot for the inspiration, unconditional love, and guidance that she has always provided me. Diabetes was called the defining disease of the 21st century in a Lancet editorial published in 2023, and for good reasons. According to data published earlier this year, the total number of people living with diabetes worldwide in 2022 is a staggering 828 million. And when you look at the map, every part of the world and every country in the world is now badly affected with diabetes. The three leading countries in terms of numbers of people with diabetes are India, with 213 million people with diabetes, China, with 143 million people with diabetes, and the United States of America, with 42 million people with diabetes. The numbers of people with diabetes have been increasing in nearly every country of the world. In 1990, there were less than 200 million people with diabetes worldwide. Now in 2022, the number is greater than 800 million. Worldwide, about half the people with diabetes remain untreated, and this proportion is significantly higher in the low and middle-income countries of the world. Diabetes is now the fourth leading cause of disability globally. It is the ninth leading cause of death. What is also important is that a lot of people worldwide now live with multimorbidity. And when you look at the conditions responsible for multimorbidity, diabetes is the leading contributor. Over the past 2 decades, we have seen a decline in the rates of diabetes mortality and complications in many high-income countries. Here are data from the United States published in 2014 in the New England Journal of Medicine, demonstrating a decline in the incidence of myocardial infarction, stroke, amputations, end-stage renal disease, and hyperglycemic deaths in people with diabetes. There are more recent data, however, indicating that some of these improvements in the United States may be getting reversed. Across the world, in several high-income countries, there has been a decline in mortality rates among people with diabetes. Broadly speaking, several factors explain these declines in mortality and complications among people with diabetes in high-income countries. These are investment in science, in infrastructure and workforce, good surveillance and monitoring, emphasis on quality of care improvement, coordinated care, and improvements in risk factor control. However, low and middle-income countries of the world have not largely benefited from these positive changes. These are data on the state of diabetes care across 55 low and middle-income countries. Care is poor on average, and specifically in the use of therapies for control of glucose, control of blood pressure, cholesterol lowering, and for lifestyle changes. The percentage of people with diabetes receiving all recommended treatments is rather small. There is a huge opportunity to improve the quality of diabetes care in low and middle-income countries. So the question really is, how can the benefits seen in high-income countries be replicated in low and middle-income countries? There is a strong correlation between undiagnosed diabetes and premature deaths from diabetes. Screening and detection can be an opportunistic entry point for both prevention and care delivery and can trigger quality of care improvement strategies along the cascade of care. Once identified, there are proven interventions, especially lifestyle modification for people at high risk, those with IGT, to prevent or delay the progression to diabetes. Similarly, once identified, there is a lot that can be done for people with diabetes to prevent complications. As this slide summarizes, we have proven interventions for glycemic control, blood pressure control, lipid control, and for use of aspirin, annual eye exams and foot exams, flu shots, and diabetes education. Together, the collective impact of all this, if well implemented, can be very, very significant. There is considerable evidence from studies across several levels, from our group and from others, that quality of care can be improved in low and middle income countries. Many of the studies have employed simple strategies like task shifting, care coordination, decision support, mobile health, and other technologies. All of this can affect improvements at the level of the patient, the provider, and the system. One example is the CARS translation trial in 1,200 patients with diabetes across 10 sites in India and Pakistan. The strategies used were care coordination and an electronic decision support tool. As you can see, compared to a control group, the intervention group achieved greater improvements in hemoglobin A1C, in blood pressure, and in lipids. And these improvements have been sustained over the last 7 years at least. Another example is the independent trial in India, which tested the integration of diabetes and depression care and showed simultaneous improvements in both of them, thus offering innovations for addressing diabetes along with its comorbidities. When India developed a national diabetes program for prevention and control of non-communicable diseases, my colleagues Nikhil Tandon and Shivani Patel integrated the quality of care improvement tools into the national guidelines. These guidelines directly inform healthcare delivery in India and thus can potentially impact health positively for 1 billion people. Talk of scaling up. There is clear recognition that diabetes, especially type 2 diabetes and gestational diabetes, are heterogeneous conditions. This offers a moment of major transformation. There is also recognition of the burdens and research gaps. Importantly, there is economic growth in many low and middle income countries which can be leveraged to invest in diabetes research and care. There is also rapid growth of many powerful tools. For example, molecular measurements, informatics and artificial intelligence, objective technology-based measurements of behavior, social factors, and environment. As you can see from this slide, there is a huge gap in terms of burden and where the research gets done. 85% of diabetes burden is in non-European populations, but only about 3 to 4% of research is done in these populations. Specifically, only 13% of type 2 diabetes GWAS studies have been done in non-European populations, and only 8% of cardiovascular disease GWAS studies have been done in the same populations. Even here in the United States, the Asian Americans comprise about 8% of the population, yet only 0.17% of NIH research dollars is spent on research in this population. I want to offer to you that leveraging and expanding global collaboration is a major opportunity for science and can benefit all and deliver health in all nations. My colleagues looked at the research gaps specifically for precision diabetes and are presenting these data as an abstract at this conference. They reviewed a total of over 15,000 publications that could be classified as precision diabetes research. They estimated the number of publications per 1,000 disability-adjusted life years, or DALYs, which is a metric of the health burden. What they found was in North America, there were 0.95 publications per 1,000 DALYs. In Western Europe, it was 0.78 per 1,000 DALYs. But in Southeast Asia, South Asia, and Sub-Saharan Africa, it is about 0.02 per 1,000 DALYs. This demonstrates that the research is not happening where the burdens are high. There are strong arguments for investing in research in low and middle income countries. Currently, LMICs invest between 0.13% to 1.5% of their GDP in research, compared to about 3 to 5% in high-income countries. Research investment has been demonstrated to correlate strongly with a nation's economic growth and health improvements. Yet, there is scant investment in research in LMICs, which is a huge lost opportunity for science. I want to briefly touch on the emerging data on the heterogeneity of type 2 diabetes. Let me start with a very simple example. Here is a comparison of two populations, both at high risk of type 2 diabetes. They are similar in terms of the high prevalence of diabetes, which is about 50% by age 55 years, but they differ in obesity and pathophysiology. These two populations are the Pima Indians of Arizona and the Asian Indians in Chennai in India. There are several differences. Firstly, in the Pimas, the bigger problem is impaired glucose tolerance and high 2-hour glucose. In the Asian Indians, the bigger problem is impaired fasting glucose and high fasting glucose levels. Although the Pimas were on average much younger, they are 7 BMI units heavier and 25 centimeters larger at the waist. On average, the Pimas were far more insulin resistant and the Asian Indians were more insulin deficient. Let's look at this chart, which shows fasting and 30-minute post-challenge insulin in both populations. At every glucose stratum, the Asian Indians are secreting less insulin at fasting and substantially less insulin at 30 minutes post-challenge. These are data published by Banks et al., replicating the Alquist 5 clusters in several US cohorts. All 5 clusters are present in all ethnic groups, but their frequencies vary. For example, in South Asians, the dominant cluster is the insulin deficient one. Jitin Varghese did a systematic review of all type 2 diabetes phenotype studies published until 2022. We focused on differences between Asian and non-Asian populations. What you see here, again, is the same thing, that the majority of studies looking at clusters replicated the 5 clusters that Alquist et al. Produced, but there were some that produced extra clusters. But what is important is the difference between Asians and non-Asians in our analysis. Across 4 of the 5 clusters, Asians had higher hemoglobin A1C. They also had lower age at diagnosis, lower BMI on average, and Asians had lower HOMA-B, suggesting lower insulin secretion across 4 of the 5 clusters. However, insulin resistance was similar between Asians and non-Asians, except in the severe insulin deficiency cluster, where Asians were in fact less insulin resistant. Overall, the literature so far, the emerging literature so far, on diabetes and prediabetes phenotypes suggests several important findings. Phenotypes differ in etiology, pathophysiology, and natural history. Complications, prognosis, responses to lifestyle and therapeutics also vary. The frequency of phenotypes vary across age, gender, and geographical location. For example, the more insulin-deficient phenotypes may be more common in non-European populations and in LMICs, which is the reason why we should go to study these populations. Asian populations may on average be more insulin deficient. Expanding knowledge in these areas can advance personalized and precision medicine and prevention. We are clearly witnessing massive expansion of technologies. Specifically, we are in an era of artificial intelligence. AI has potential applications for understanding disease, its risk factors and prognosis, for prediction of disease and complications, for informing precise therapy, and for improving delivery of prevention and care. There is also a huge expansion of therapeutic options. As we speak, there is currently at least 12 groups of drugs with different mechanisms of action. However, when we examine the usage of the drugs, even in the United States, the newer medications are used less often. The main reason for this is cost and access. We need to work on lowering cost and improving access so that all people and all populations everywhere can benefit from these powerful therapies. As an illustrative example, my colleagues estimated the potential impact of ensuring worldwide access to GLP-1 RA for all who meet the criteria for their use. These data are presented as an abstract at this conference. Over a 5-year period, based on simulation modeling, we estimate that if universal access for GLP-1 is achieved, the prevalence of obesity globally would be reduced by about half, or we would have 550 million obese people fewer within 5 years. All-cause mortality globally would go down by close to 7%, and that would translate to 37.5 million fewer deaths over a 5-year period. What can we do to improve diabetes and prevention in low and middle income countries? There are a few publications that have comprehensively addressed this. My colleagues and I led the diabetes analysis for the World Bank Disease Control Priorities Project. We published 2 editions of this. We analyzed diabetes burdens, effectiveness and cost-effectiveness of various interventions, feasibility of delivery, and arrived at prioritized lists for implementation across countries. More recently, led by Juliana Chan, this year's Kelly West awardee, a Lancet commission looked at ways in which diabetes prevention and care can be improved across the world. Sponsored by the world's largest philanthropy, the Novo Nordisk Foundation, the Global Diabetes Forum, a group of 51 experts from 27 countries, met over a year's process and developed a transformative vision for global diabetes and produced what is called the Copenhagen Declaration. The Copenhagen Declaration is a blueprint for diabetes research and care in an interconnected world and was recently published. The full report is available to download from this URL site below. Lancet Diabetes Endocrinology also published the Copenhagen Declaration, and the citation is listed in this slide. The principles driving the Copenhagen Declaration are the following. First, we should leverage emerging knowledge in diabetes heterogeneity, advances in diagnostics, and therapeutics. Second, we should strengthen health systems through scalable, affordable, multidisciplinary care. Thirdly, we should ensure equitable access to innovative resources and treatments and technologies. Finally, global research collaboration is needed to bridge the knowledge gap across diverse populations. This slide pictorially represents the main message behind the Copenhagen Declaration. The goal is to reduce the global burden of diabetes. To do this, we propose improving collaboration and investment, expanding implementation of quality of care, and pivoting precision diabetes. I want to thank the numerous and diverse funders who have supported our work during all these years. To resonate a global vision, I would like to conclude with a poem from the Nobel laureate Rabindranath Tagore. Where the mind is without fear and the head is held high, where knowledge is free, where the world has not been broken into fragments by narrow domestic walls, where words come out from the depth of truth, where tireless striving stretches its arms towards perfection, where the clear stream of reason has not lost its way into the dreary desert sand of dead reason, where the mind is led forward by thee into ever-widening thought and action, into that heaven of freedom. My Father, let my country, let my world awake. Thank you very much.
This concludes our 2025 award ceremony. Thank you for attending, and congratulations to all the awardees. Please enjoy the rest of your day at the 85th Scientific Sessions.